Hello, everybody, and welcome to another amazing episode of Dentistry Unmasked. I'm Pam Maragliano-Muniz. With me, as always, my partner in crime.
Hey Pam, David Rice, good to see y'all.
Good to see you. This topic is going to probably make a few hearts race and maybe get a little sweaty because this is a topic that is pissing people off or bringing relief to your practice. Depends on how you look at it. David, how are you feeling about dental assistants doing the job of a dental hygienist?
Can I just be super blunt?
Yeah.
If you want to be a dental hygienist, go to hygiene school. If you want to be a dentist, go to dental school. Otherwise, stay in your lane.
You can't do the mic drop in the beginning of the podcast. You got to do that at the end.
No, let's just go all at this thing, man. It's just people are like tiptoeing and trying to be like all friendly. What do you ladies think? We got two
Well,
incredible people here.
I was going to say, speaking of tiptoeing and not being blunt or opinionated at all, we decided to bring on Dr. Mia Geisinger and Katrina Sanders Stewart. Welcome, ladies.
Hello, hello.
Great seeing you,
So,
ladies.
so good to see you
It's good to be
guys.
seen.
So,
Hmm.
Katrina, this is happening in your backyard.
Sure is. Yeah.
And how's that going?
So, Dr. Rice already began with the provocative statement. So, is it cool if we go there? Can we get provocative about this and like roll up our lab coat sleeves and
I'm
really do the
wearing
thing?
a wine shirt today. Where's
Okay. Oh,
the
yes.
content?
I'm loving the shirt, by the way. So let's start with the beginning, which is yes, this has passed in the state of Arizona. And of course, the fear and the concern is that this will likely begin to occur in other states. This is not a new bill, in that it has been proposed in other states, most specifically Montana, and then recently Colorado. And in those states, the Hygiene Association was consulted and they were permitted the opportunity to share their professional recommendation, opinions, and create a collaborative approach. To my working knowledge, the main talk track around leveraging the use of dental assistants in this state, in Arizona, to perform prophylactic scaling was really based on the concept that we had a workforce shortage of dental hygienists and we have an incredible need of our patient population community. And so the talk track was really about the hygienists are not stepping up to do the thing they need to do to serve the healthcare needs of the community. So now what are we going to do? And that's kind of been the assumption of what that talk track was, down at the Capitol here in Phoenix. Here's the challenge. The Arizona Dental Hygienists Association was not consulted on this at all. And so I think in order for us to really understand what happened here, we have to get to like we do in dentistry, the root cause of what happened here, which is I do not believe that in many cases, the dental association and the interests of our doctor practice owners are collaborating with organized hygienists to say, we have a unique problem. And instead of making the hygienist his or her salary request, his or her prima donna status of wanting to have new ultrasonic inserts and the equipment they need to do the task they've been hired to do, and all these things that have seemingly over the years made us prima donnas. Instead of coming together and saying, we have a challenge and we look to you as the other licensed professional in the practice to help us solve that, instead of that, unfortunately, hygienists were stepped over in the state of Arizona. And it was like we blinked and overnight this bill got signed into law. So, my challenge inside of all of this is if the talk track was that hygienists are not serving the needs of the patients, is there an opportunity for us to identify why that is, where that came from, and most specifically, why the hygienists were not involved in the discussion around a hygiene problem, which is successful maintenance of our patients and our patient population community. So I think to take it a step further, we're seeing other states now permitting dental assistants the opportunity to do things beyond scaling. Most notably, the state of Oregon now is permitting dental assistants to perform local anesthesia. And to be very clear, this isn't simply infiltration local anesthesia, which dental hygienists in the state of Texas just recently passed. This would permit dental assistants to perform block anesthesia. So I will say there are challenges in this, and hygienists, of course, have their eyeballs on it, and there are a lot of reactions to it. The concern for hygienists is not about the safety and the security of their job. Not a single hygienist who I've spoken to has said, I'm concerned about my job. I'm concerned that an assistant is going to just take over and do my work. If you talk to hygienists in the state of Arizona, their concerns are about the safety of the patient population who will likely receive care from these dental assistants. And so that's where I think we have to take a look at the full scope picture. If we're talking about needing to create some kind of scaling dental assistant to meet the healthcare needs of the population, are we really thinking about how to safely and effectively address those healthcare needs?
So, okay, I'm going to cut this back to a little bit different. Senorita, everybody knows my dog, Senorita. So back in the day, I used to send her for anesthesialist dental appointments every 6 months, figuring let's, get ahead of this and we're going to do that. So anesthesialist dental appointments for dogs was outlawed in Massachusetts because of the safety of just providing a supragingival scaling. Because if you can't get subgingival and you can't obviously take care of the biofilm in the hard to reach areas, you're not getting that person healthy. So, Mia, my question to you is, as a periodontist, if we're just providing supragingival scalings, are we really helping, humans at large here?
Short answer, no. Long answer, it could even be worse than that. So, one of the things that we know is that the perception often is, well, something is better than nothing. And the truth of the matter is sometimes something is worse than nothing. And that may be the case for supragingival scaling in the presence of periodontal disease. So if you have a patient who has periodontal disease and you perform supragingival scaling, yes, you will see plaque indices above the gum line that you can measure go down. What you will not see is changes in probing depths, in clinical attachment loss, in bleeding upon probing. And what you can see is actually that the biofilm becomes more pathogenic because what repopulates that biofilm? It's now the subgingival biofilm that is facultative anaerobes, that is the bad guys for periodontal disease. And that's what we've left because we've taken all the commensal bacteria that are aerobic bacteria that live above the gum line away. And now the facultative anaerobes, the bad guys, have nobody to compete with. So of course, they're going to kind of take over. And so we see a shift to dysbiosis at a much earlier phase when you do supragingival scaling without subgingival debridement. Further, scaling, in perio, we talk about scaling and root plating, right? Scaling is just the removal of hard and soft tissue accretions. But in many cases, patients who may have gingivitis, right, they have gingival edema, gingival erythema, and so their gingival margin is actually above the CEJ. So if we are not going in and getting subgingival in those cases, we may, even in gingivitis cases, we may be leaving significant amounts of plaque and calculus that then set that patient up for progressive disease. We have to be able to do our job in its entirety. And I think it does a disservice to our patients to treat them in a halfway or a sort of well, we'll just kind of clean around the area and we won't worry about what else is going on. If we treat all patients, all cleanings as equal, I think that's a big mistake. But here's the other thing that I know. The scaling and root planing even alone is not sufficient to maintain health if a patient is not doing what they need to do at home. And a critical role that a dental assistant can play in the dental office is as an oral hygiene coach. That is something where we desperately need from a public health and even a practice health standpoint. We desperately need people who can help our patients get to where they need to be, because I can't show up at their house and brush their teeth every day. Katrina can't show up. You guys can't show up. Very few people could afford to pay us what it would take for us to clean their teeth every day, twice a day. But we need to equip them with the ability to do that. And I think, when we think about the public health impact of really tuning up and doing better oral hygiene, versus, just sort of running an instrument around their teeth, I would much rather see time invested and resources invested in developing skills and providing equipment to get patients where their home care needs to be, and have a dental assistant really be the champion of that in the office, and take that off of our hygiene partners' plates so that they can be more effective in managing their appointments and their time, doing that part of their practice to the best and highest of their abilities.
So, Pam, why do you think dentistry knee-jerk reacts and does what's happening right now?
I think that I don't know. Obviously we know that there is a shortage of dental hygienists. We lost a significant percentage of hygienists during the pandemic, and we haven't been able to recoup that. And my heart goes out to those offices that are, maybe the dentist is providing their own prophies, which even that I don't think is great. Um, you know, and I think also maybe it's a little bit of an FU to the wage demands, because hygienists kind of answered back like, there's not enough of us, so guess what? Time to pony up if you want me. And so I think that there could be, as most things, multifactorial. I feel like that's part of it. But I guess my other concern is that, and I don't know the laws in Arizona as it pertains to dental assisting licensure, but there are assisting schools that have programs. There's on the job. At least in Massachusetts, you can go to Maine and get EFTA training. So you're a different kind of assistant than, say, somebody who is on the job trained. And so, but you can all have dental assisting licenses here in Mass. And so I know my assistant that's in EFTA was like, I wasn't trained to subgingivally scale. I would never pick up a scaler other than to clean maybe temp cement around a temporary or something like that. I don't want to do that. So I guess I'm curious, why would assistants want to do that? Because are dentists going to be like, well, cool, my friend assistant that's been here, you're going to now scale teeth and I'm going to pay you like a hygienist to do so. I somehow doubt that's going to happen.
Interesting that you bring this up. In the state of Arizona, dental assistants are not required to hold any kind of certification or licensure. So you can take an individual off the street, train them on how to hold a section, and they can become a dental assistant. Now, I think it's important for us to take a step back to something really valuable that you said, Dr. Pam, and that was, maybe this is an FU to hygienists who recognized that this was a supply versus demand issue, and that hygienists could say, well, I would like more of a higher rate fee because I can just go to the office across the street and make more money over there. I think we have to acknowledge that just like dental assistants, just like doctors, that there is a spectrum of clinical acumen and skill of hygienists. So here's the other side of this. And this is, we're going to get a little provocative here, but I think it's important to call this out. This OPA bill that was passed in Arizona means that the assistant can scale. However, they cannot use an air polisher. They can do coronal polishing, but they cannot use an air polisher. They cannot probe, and certainly they can't diagnose a perio case. So, the question that I had to ask my colleagues in the state of Arizona, as somebody who goes into a lot of our referral practices and consults and does chart audits and chart reviews, where we are looking at how often does a hygienist probe a patient? How often does a patient, when they come in and they're scheduled as a prophy, how often does that patient actually just get whatever they were scheduled for instead of leveraging clinical decision making of that hygienist to say, hold on a second. Sorry, David. I know you thought you were coming in today to get your free cleaning your insurance covers. Oh my gosh, we did an assessment today and I'm not an order taker. I'm just not going to do your free cleaning today. We need to talk about the gum disease you have in your mouth and the fact that we need an advanced treatment. And so it's interesting because a lot of hygienists have fears that inside of this assistant scaling bill, that these assistants are going to be expected to manage their own columns of pro fees where they're not going to be probing these patients and then assessing appropriately. And so, Dr. Mia, what you had shared is super accurate. What is the concern that these patients who maybe have underlying early perio are subsequently receiving pro fees? But we have to go back to this issue of how often is that currently happening in practices? And that is an uncomfortable truth. As a hygienist who I believe loves to advocate for other hygienists, the reality is a significant portion of my colleagues who have those 3 letters after their name did in fact go to hygiene school, did in fact take their boards, and proudly say that they're hygienists, are oftentimes those prophy princesses that are sitting in these practices and asking for an incredible hourly salary in order to perform bare minimum dentistry. And so I think we've got to take a step back and acknowledge that this is another contributory factor in that root cause, which now has our doctors saying, well, if all these prophy patients in these hygiene columns are just going to get whatever our office manager tossed into the Dentrix appointment book today, then why don't I just have somebody who can do this for cheaper and is not going to be a prima donna about it, do it? And so I think we see the other side, the ugly underbelly of some of this, deep-rooted, problematic challenges that have been consistent. When I talk to Dr. Pam, you love your hygienist and you speak so highly of them, and they in turn love you. That's a really special thing that when I talk to many other doctors in my travels, they don't say that with the same level of admiration for their hygienists. And so I think we have to acknowledge the challenges in that for a long time, hygienists have wanted to do things like diagnose perio. And we've been held back in being able to do those things. And so it's created this long-term challenge of who's responsible and actually accountable for this disease. And the reality is enough times of me, and the irony is I speak on staging and grading because Dr. Mia Geisinger is one of my best friends in the whole wide world. So I feel like by proxy, I know staging and grading, but I teach staging and grading to doctors. I teach it to doctors. I can't stage and grade a patient, but those doctors sitting in my room can. And so again, it starts to create this challenge of who's ultimately responsible for this disease. And currently, in most states across the United States, the responsibility is that of the doctor practice owner.
So what do these hygienists do? So, okay, now it's just kind of a question more than anything else. So, all right, I say this hygienist X is a hygienist and she's excited about perio. She wants to do all these things. She works in a practice and she says, Doctor, I want to probe my patients. I believe that I can help eradicate periodontal disease in my operatory, and I think I can do it. I just need the autonomy to do so. And doctor says, oh, hygienist X, that's cute. No. So does hygienist X go find a job where she'll find a practice that will allow her to do what she wants to do? Or does she say, cool, I'm now Prophy Queen? I mean, I feel like I don't know if that hygienist is going to ever be a prophy queen. I think she just needs to find the right place. And I think some prophy queens are prophy queens, like it's in their DNA. You know what I mean? I feel like I'm not sure that we're turning them into that, but I also think that I feel like I don't know. I have a girl, a woman, young woman who's in college to be in hygiene school now. She was an assistant. And I feel like she probably thinks I'm crazy because I was like, I need you to listen to what I'm about to tell you. You need to like feel it. You need to know it in your soul. Like you need to it's got to be part. Like you got to sweat it out. It's in your body, in your soul. You need to know that you can get people healthy and you need to believe that. She's like, okay. I'm like, no, you need to believe it. Like it needs to be like you need to like own it and have it and live it and breathe it and know it. And she's like, okay. And I'm like, nope, you need to, it's got to be there.
Do it. Come on.
But I don't know if people feel like they can do it. And I think that's kind of where we can feel challenged as oral health care providers.
I want to know what Dr. Geisinger believes about this as a periodontist and as somebody who interacts with periodontists, because I will tell you, I think she's going to give you a very specialized answer that is quite iconic of periodontists and their belief of hygienists. But the one piece I will say before, because I know Dr. Geisinger is going to do a mic drop on this one, I will say boiling water will harden the egg and it will soften the potato. And that's really important. It's an important concept because some hygienists will graduate from hygiene school with that fervent passion to do the right thing. They'll get into clinical practice and they will be told, just sit in the corner and clean teeth all day, and you're not allowed to have an opinion. And some of them will say, absolutely not. I'm going to rise above. I'm going to leave. I'm going to leave you. And I'm going to go find a practice. I'm going to go find a Dr. Pam who's going to appreciate me and allow me to step into my power as a clinician. But there are other hygienists who are in these practices. And I know that many of them are listening right now and nodding as they're on their way to work, driving and going, oh my gosh, I'm driving into a practice where I'm being suppressed. I'm being told to be silent and that I'm not allowed to have an opinion. And so I'm being bullied into being a prophy princess. But Dr. Geisinger, what are your thoughts on this?
Well, I mean, I think all of us, all four of us have been on these mics before. And I have said, as a periodontist, right now there are about 6,000 practicing periodontists in the United States. There's a heck of a lot more dental offices out there, and certainly a heck of a lot more dental hygienists. So, for me, I can't be in the office with every one of the general dentists in my community. But every one of those general dentists has a dental hygienist. And so that dental hygienist, he or she is the periodontal professional for that practice, for that community. And I rely on their expertise in that general dental office to identify patients who may need higher level care, to bring that to the attention of the practicing doc in the office, and to really advocate for their patient to get the care that they need to become healthy. And as you said, Pam, really, believe that they can, in partnership with their dentist, with a periodontist, maybe with other interprofessional dental healthcare providers or medical healthcare providers, make that patient healthy. Katrina knows we don't call the hygienists that work in our practice, we don't say it's our hygiene department. We call it our wellness department. Because they're in the wellness business, and we actually screen for systemic disease. They do nutritional counseling with our patients. They probe every single time those patients come in. They are on it. And 30% of the patients that they see in a periodontal wellness practice have other dental needs that then get referred out from our practice, where they need a crown or they need a new RPD or they need a occlusal guard made. So we actually have become a referral source for our referring practices. And that also can be a teaching moment where we can go back and forth as we, continue to treat those patients. So I'm very grateful for the dental hygienists that I work with. And I'm also very grateful for the dental hygienists who are doing yeoman's work in practices. But I know that when I talk to dental hygienists, one of the comments that I often get is, I know I see patients who have 6 and 7 millimeter pockets even after we do non-surgical therapy, and I want to refer this patient for advanced care, whether that's laser therapy or regenerative surgery or resective surgery or whatever it is. I want to send them to a periodontist for advanced care. And I'm told that we keep all those patients in-house and we'll keep them on our maintenance schedule and we just see them more often. And that is frustrating for them, I'm sure. And I can imagine that if that is your reality day in and day out, that you do have to make a decision, whether you stay and just bite your lip and do what you're told, or whether you go. And for many folks like Katrina, she chose to work in a periodontal practice, and she chose to advocate for dental hygienists. But I think it's a tough choice too, because everybody needs to have a job and needs to eat and put a roof over their head. So, it's hard, but I do think that when we center the patient and their best interest in what we're doing, the choice becomes a lot easier.
So I love this conversation, and I'm going to say you're on the top, let's say 2%, but on your worst day, 5%. So the reality is there's 95% of our profession out there who does not walk, talk, or think like any of us walk, talk, or think. And that's not a knock on them, because I think what you just alluded to, Mia, is even another layer, is like, why do those dentists keep those patients in their practice? Because they're feeling the same economic pressure that the hygienist is, who says, I'm going to put up with this because otherwise I'm driving 20 minutes to find a practice or an hour. So rewind to the practice who's getting $60 for a patient to sit in a hygiene chair. And at that point, if you said the top 5% are going to say, you know what, I'm going to live in a cardboard box to do the right thing, the 95% are going to be human and say, that's not my problem. That's that patient's problem for having crappy insurance. And that's where I think a lot of this begins, right? If everybody got reimbursed what they should get reimbursed, the right thing would happen all day, every day, most of the time. But the reality is there's a lot of practices out there who can't afford to treat their patients the way their patients are supposed to be treated. And I'm interested to hear what you guys think about that. Because my answer to that is like, well, don't play the insurance game. But that would, someone of you call me a prima donna for that, right?
I actually, I would disagree with calling you a prima donna for that. And here's why. You take into consideration current local events that have opened up the floodgates for discussions about whether insurance companies, healthcare, dental, or otherwise, are truly advocating for their subscribers. And I'm saying that lightly and delicately. But I think it really created an opportunity to help share some awareness about the financial gain and the financial interests of some of these organizations that are truly capitalizing on the suffering, the illness of others, and truly finding opportunities to not take responsibility and support their subscribers in the things that were a part of the agreement when the HR department of that employer agreed to. I had a nasal surgery done last year twice. The second time I had nasal surgery done, they said you need to be like fully under general anesthesia for this. So I did. I went under, and I thought everything was taken care of. I have insurance through my employer. Well, wouldn't you know it, I got a letter from the anesthesiologist. It's actually sitting right here on my desk. And this letter from the anesthesiologist says, I'm writing to you today about your anesthesia claim. They tell me that this anesthesia claim was submitted to my insurance, and my insurance company does not believe that they are responsible for paying my anesthesia. So this is a situation where an admin, Susie Q at whatever insurance company, made the decision that I didn't need anesthesia for the serious procedure that I had done. That's her opinion, but we also know, again, that there's a vested interest financially in my insurance company not paying for this. And so whether it's the fees that have been negotiated or haven't been negotiated in many, many, many years, or the denials, or the guardrails of you can't do SRPs on a patient until they look like this. The challenge is, for a long time, we've taken that responsibility on instead of saying to the patient, your insurance company wants me to wait until this gets worse. That's what they're expecting me to do. And so what was cool about this letter, what was cool about the letter from my anesthesiologist that said that my insurance is not paying, is that they said, we actually don't believe that you're responsible for this balance. And it gave me some instruction on the things that I can do as a patient to advocate for myself. So I don't mean to say that that's the perfect solution for all of this, but I do think there's an opportunity for us to take back some control and onus on what our responsibility is. On my graduation day, I promised the community when I said my oath that I would help them for better or for worse, like through whatever healthcare needs they had. I did not, in my oath, promise that I would curate my treatment planning style to meet the unique needs of insert dental insurance company. So I think it's important for us to help also advocate for our patients in full transparency around a lot of this. But the other side of it is, as Dr. Geisinger brought up, if our general doctors are not referring perio cases that are considered so advanced that they were non-responsive during treatment, and subsequently we've decided a hygienist has said this is an advanced probing depth, an advanced bony defect, etc., and I believe a specialist needs to see this, and dentistry is choosing not to refer that patient because we're afraid that we're going to lose that patient, then again, we are choosing fear and money instead of the best health outcome interests and long-term solutions for our patients.
So that's my other question. So there's 6,000 periodontists, in the country, however many dentists, hygienists. There's a lot more people, patients, end users to the care that we have. I would be really upset and I would feel very duped if I was going for my hygiene visits as per the recommendation of my dental team and I'm becoming periodontally less healthy because of the fact that somebody who has a license because the state says it's okay, but not the education and expertise to provide the care that I need, I'd be really upset. I mean, I would actually think that maybe over time there could be a liability there, really, for that practice.
So the worst question I have to answer, and on a daily, weekly basis, is I give a patient a diagnosis. I say, Mrs. Jones, thank you for coming. We did your radiographs. We took measurements around all of your teeth, and we determined that you have stage 3 grade B periodontitis. And here's what that means. And oftentimes the next question is, well, how long have I had this? Because I go every 6 months.
Yep.
And, I think from my perspective, one of my worries about a practitioner with a limited scope and an inability to diagnose is that we'll see more and more of that, where we are essentially looking at problems in a uniform manner because the skills we have only allow us to treat things in a uniform manner. My understanding, and Katrina, you can back this up, is that patients have to be informed of the individual that they're seeing. So patients have a right to request to see a dental hygienist based upon the way that the regulations are written in Arizona. And they can ask, is the person doing their cleaning that day an OPA or a registered dental hygienist? And I think the public should, understand the difference between those practitioners and what their abilities are.
Do you think that'll happen though?
That's the key issue. The word should. We should be doing this. And this is the slippery slope that a lot of us hygienists fear. Also, the OPA should only be able to scale above the gum line. However, is that the reality? This is under direct supervision. The doctor should be coming in and probing that patient initially to capture a diagnosis. The doctor should also be checking that assistant's work before the patient is dismissed. All of this is should, and should. And unfortunately, I think we're shoulding all over ourselves when it comes to this, because the reality is, I think we all know the culture and the type of practice that will likely adapt to a model like that. And I'm making assumptions here, but the assumed dental IQ and socioeconomic status of individuals who will be seeking care from those practices, where I don't know if these patients will be empowered to understand that they do have the right to ask, who are you? What is your training? And I would like to receive my care from a more skilled clinician. I think those are the fears. I don't mean to say that they're reality, but those are the immediate reactions and fears that a lot of licensed hygienists have, again, in protecting the vulnerable populations in our community who will likely experience this initially.
So nice work, dentists of Arizona. Sounds like you just pissed into the wind because you just made your job harder. You have more responsibilities now during the dental hygiene visit, where before we just had to perform a periodic exam because we can trust that our hygienists are looking for subgingival calculus and they're, providing probing depths. I mean, I don't probe during my periodic exams. I review the perio chart that's been completed. So, yeah, I think hopefully the rest of the country doesn't follow suit, and hopefully I wish Arizona would fall in line. Again, heart goes out to the practices and the patients where they don't have the proper team support, but I'm not sold this is the answer. In fact, I would have to say it sounds like it's not the answer. David?
Yeah, it's, I get it. We have problems. We discussed all those, but it's, what is that phrase? Like you're jumping from the frying pan into the fire. So we haven't solved anything. We've just added layers of complexity and complications that our patients will experience. And I'm disappointed. And I think I'd love to hear from you, dentist, if you're listening in, and you're not. Convince us otherwise, but I can't find one rational argument for this other than, to your point, Pam, dentists said, screw you for asking for too much money. And although I understand that sentiment, this is not a solution.
Absolutely not. And if there's any patients listening, advocate for your own health, because clearly you might not have the person advocating for you that should be. So it's on you to make sure that you are being cared for the proper way, and that you are, in fact, taking the time, effort, and money to sit in your butt in that chair. You should be leaving healthier than you got there. So, Mia, Katrina, thank you so much for your time today and your expertise and your opinions and your candor. So we are out of time for today, but I don't think this conversation is over. So you might just have to come back.
Well, thank you for having us. It's always great to be here. And anytime we get to talk nerdy, we love it.
That's right. Thank you so much.
Thank you. And we will see you soon. And everybody, for Dentistry Unmasked, we will see you all next week.
Thank you, everyone, for watching or listening to the show this week. And thanks to our guests and sponsors on this episode.
Please check out our social media at Dr. Pamela_Maragliano and at Dental Economics Official.
Or you can check me out at Ignite DDS or at Dr. David Rice.
And go to dentaleconomics.com to receive dental economics. You can choose to receive DE in print or digitally, and you can also get the details of our Principles of Practice Management conference on our website.
If you have topics or guests or anything you'd like to talk about on the show, send us an email to dentistryunmaskedpodcast@gmail.com, and we will do our very best to make it happen. Thanks again, and we'll see you next week.